reflects positively in our patients in the ICU in the whole kingdom. So the agenda of today, I'll give some introduction about the neuromuscular blocking agents, their classifications, mechanism of actions, interactions, indications and evidence behind it as well. And in the indications, I'll be talking about ARDS, RSI, asthma, brain trauma, and high ISP conditions, therapeutic hypothermia. And then I'll talk about the safety issues about using neuromuscular blocking agents in the ICU, monitoring for patients that receive neuromuscular blocking agents, and some bedside measures that you have to take care when you are dealing with patients on neuromuscular blocking agents. And if we have time, we'll cover, in a few slides, the referral agents, and we'll come up with the home messages, take-home messages, and recommendations. Classification. So neuromuscular blocking agent could be classified, according to the chemical structure of the drug, or according to the duration of action of the drug. That's the main type of classifications. If you look at this table, do you see the tables? Yeah, live. Yeah, great. So if you look at this table, now I summarize on the left side here the most common type of neuromuscular blocking agents that we use, and then I categorize them accordingly if they are depolarizing or not. So you can see from the slide, acetylcholine is the only one is depolarizing drug, and it acts by binding and activating the nicotinic acetylcholine, and that will cause persistent depolarizations and make paralysis of the muscle. Rocuronium, atrocorium, cisatrocorium, the vicuronium, they are non-depolarizing and they are competitive. So they compete as antagonists to the nicotinic receptors, and this will result in the prolonged paralysis of the muscle. But they are competitive, so put this in mind. We'll come to this later on. Among the 5 types of neuromuscular blocking agent that we have, the only one that cannot be used by infusion is acetylcholine. We usually give it as a bolus, and most common indications, or maybe the only common indications of acetylcholine, is to do intubation, rapid sequence intubation, mainly for unplanned type of intubation. So we use it a lot in the ICU and in emergency. The problem with the acetylcholine, it has no referral agent, so be careful. If you are not really good in doing intubations, you have to have a backup before you give the patient acetylcholine, otherwise you will have trouble in putting the tube down. Rocuronium, atrocorium, cisatrocorium, and vicuronium, they all have infusion and boluses as well, according to the need and the indications. And all of them, they have referral agents, and there are 3 types of referral agents that we can use. Sagamidix, one of them that we can use commonly for rocuronium, and eustegamine and pyristegamine we can use as well. And among the non-depolarizing neuromuscular blocking agent that we can use in rapid sequence intubation, only rocuronium. It has very good evidence, actually to beat very well acetylcholine in rapid sequence intubation. There are some medications that might increase the potency of neuromuscular blocking agents, so be careful with those, like diuretics and antiarrhythmic medications, etc. And there are some other medications that decrease the potency of neuromuscular blocking agents, as well as the hepatic and renal failure that might decrease the clearance of the drug. Histamine release and vagolytic actions, major side effects that we have to take care of when we give patients neuromuscular blocking agents. Histamine release is specifically with atrocorium, and that might cause sometimes hypotension. So be careful if you have patients with allergy or anaphylaxis. Do not give them acetylcholine because it basically releases more histamine and causes more hypotension. Cisatracorium in the other side is the less likely to be histamine releaser among the non-debilitating drugs. Now, regarding the vagolytics and the cardiovascular stability, pancuronium is the worst. Do you have pancuronium here in National Guard? Do you use pancuronium? Maybe no. So it's not in use. I don't think it's in the clinical use as far as I know. Now, if you are still using, please share it with us in the chat. Rocuronium can cause tachycardia, but sometimes it's very rare. Vicuronium can cause as well tachycardia, but mainly bradycardia. Cisatracorium is the safest non-nebulizing drugs that you could use in the ICU. Sux, we use it for rapid sequence intubation. Rocuronium, the same thing. The beauty of Sux and rocuronium, they have rapid onset of action and short duration. Sux is very short, up to 9 minutes. Rocuronium, a little bit longer, up to 40 to 45 minutes. But the beauty of rocuronium, as we just mentioned earlier, it has a reversal agent. So if you're not happy with it, you just could reverse the drug. Great. So what are the benefits of giving? Now that we finished now the discussion about the boluses and rapid sequence intubation, mainly with the succinylcholine and the rocuronium. Now I have to mention, in succinylcholine, you have to be very careful with patients with the severe septic shock, patients with renal failure, hyperkalemia, and acute stroke. They might have complications, mainly hyperkalemia. So be careful with those. And rocuronium, be careful with the patient who has allergic to amino steroids because it's the same derivative as rocuronium. Great. Now let's talk about the bulk of the discussion. The infusion of the neuromuscular blocking agent in the ICU. It's not uncommon to see patients paralyzed in most of the ICUs in the kingdom and worldwide as well. And we'll talk about this momentarily. The reason that most of the intensivists and clinicians use neuromuscular blocking agent because some small studies show some theoretical benefit of its use, and mainly the desynchronizations between the patient and the vent. Some studies show that might reduce the intra-abdominal pressure. It might improve your oxygen exchange, and it might reduce the risk of barotrauma, and there's good evidence behind this. And it might decrease the consumption of the oxygen and energy that sometimes you need in a patient with brain injury and patient with therapeutic hypothermia post-cardiac arrest. Now that all of these are theoretical benefits. Do you really have this in clinical practice? The only way to answer this is to look at literature. So in the next few slides, I will go through the very updated literature review about use of neuromuscular blocking agents in ICU patients. And that's one of my take-home message slides. Those are the conditions that commonly we use RSI on them. Patients with IRDS, status asthmaticus, brain injury with high ICP, plastic, or especially the graft surgery, therapeutic hypothermia. And unfortunately, none of them has very strong evidence behind its use. So we are using drug without very solid evidence about its use. Still we use it, but we have to be very careful and we have to know the details of this presentation before you decide to give neuromuscular blocking agent to your next patient. Now, while we talk about this, it has been a problem since almost in the 1980s. It has been shown that most of the patients in the ICUs, almost in one study, 90% of the patients in the ICU are paralyzed. People get more knowledge about neuromuscular blocking agent, about their problems, about the issues, the side effects, the complications. the mortality rate with its use, and they start to use it more or less than before. And in 2005, there's good articles showed in one center there's only a decrease to only 13% of the patients who are mechanically ventilated, they are in paralytic agent. So there is worldwide decrease utilizations of the neuromuscular blocking agent. Unfortunately, we are still using a lot of paralytic agents in our ICU patients. Now let's take one by one. ARDS, acute respiratory distress syndrome. Most of the therapeutic strategies, either pharmacological or non-pharmacological, in ARDS, they're not very, very strong, except maybe they are the SNET trials. And most of the strong evidence behind treatment of ARDS are those for non-pharmacological measures and procedures. It has very good evidence. Now, for pharmacological interventions, almost nil, 0 to nil evidence of any type of medication that could improve outcome in patients with ARDS. So, and for this reason, before you decide and to open the chapter of using neuromuscular blocking agents, you have to utilize all other resources before you jump and give paralytic agent to patients with acute respiratory distress syndrome. Why is that? Let's look at the evidence. Now, this is a review. It's only a review article, but published in 2002, just recently, by a group of pharmacists, and they look at the literatures from 1990s up to 2020, and they come up with the conclusion that there is no mortality benefit of using neuromuscular blocking agents in patients with acute respiratory distress syndrome. But maybe it could help in the mechanics of oxygenations and decrease, patient ventilations discipline. Another study, a little bit old and not very strong study. It has very good number, but the problem is the methodology. They look at retrospectively at a very large study, and they look at patients who are paralyzed and mechanically ventilated at the same time, and they want to look at the outcome. Their conclusion in this study, it basically increase the mortality rate in those patients. In 2004, there is another article, but unfortunately, it is not clinical outcome article. It's only gas exchange, and it has only 56 patients on the study. So it's small study, no clinical outcome study, and it's negative. It's positive, but mainly for the oxygen gas exchange. But did not mention anything about mortality. That's number one. Another one in 2006, small study again, 36 patients. The objective is to look at the indicators and inflammatory markers in ARDS. It's not really clinical outcome indicators, and there is no benefit again, and it has small size. Another one, but very good number of study, 340 patients. It has positive outcome, but I'll talk about the study in a moment. This is the only one that has positive outcome. Well, the main problem with this study, although it is positive, it's not blinded, number one. Number two, the same author who had this study, he's the same author of other 5 studies that we just talked about. So you can't, questioning the methodology of this study because they are the same investigator. If you look at the Chinese one in 2014, it came up with a negative result. There is no significant difference in 21-day mortality rate if you use neuromuscular blocking agents in patients with neuromuscular blocking agents in patients with acute respiratory distress syndrome in the ICU. Another small trial, only 30 patients. Again, the concern is the size and there is no clinical outcome study. That's what I was talking about. So most of the positive studies come from the same author, the same institute, the same center. So it's not multi-center studies. It's basically a single center study. Plus, it's not really blinded, and it has the same author. So you start, questioning the validity and the applicability of the study worldwide. That's the one that maybe we have to spend time on. It just published last year in New England, so very good journal. And there is, I could say, there's no contaminations with other RDS investigators. They look at 1,600 patients, and the trial was stopped earlier because of futility. And their main outcome is clinical, which is the 90-day mortality. There is no difference in the 90 days, although there is more side effect if you use neuromuscular blocking agent. Now, to put all this article together, to put all this randomized controlled trials together, we have another 2 or 3 review articles, meta-analysis, and all of them in the last few months, in the last 2 months. This one is looked at the 5 articles, except the Chinese one, and their conclusion, there is no benefit of using neuromuscular blocking agent in patients with ARDS. And those are the studies they looked at. There's no difference in mortality. There's no difference in mechanical ventilation durations, the free day of ventilation as well, and the oxygen, the PaO2 FiO2 ratio. So it was mistaken that here. Another meta-analysis in the +1, it's still a very good journal in 2020 by different group. They include the Chinese study. Again, there is no difference in the mortality if you use neuromuscular blocking agent. This is the primary outcome, the mortality, and this is the secondary outcome. There is no significant difference in 90 days ICU mortality. Last but not least, this is another meta-analysis for, again, 6 trials with 1,500 patients. They look at the benefit and the outcome, and if there's any harm of using neuromuscular blocking agent. And there is conclusion, there is no significant effect of neuromuscular blocking agent in moderate and long-term mortality. But it does increase your ICU acquired weakness in the ICU. So my advice for neuromuscular blocking agent and ARDS, number 1, do not use it routinely for every ARDS patient. Number 2, you might use it in severe ARDS if you use all other measures and fail. And specifically to decrease the chance of barotraumas and desynchronies. And if you want to use it, you have to use it in short durations. Let me take questions now or later after the finish. Okay. If I have any questions, so that's the summary of using neuromuscular blocking agent in ARDS, and this is the take-home message. There is good evidence for its mortality. There's no evidence for mortality, but there is maybe some evidence of its harm and ICU paralysis. Now, what about status asthmaticus? Strange enough, the 2017 Society of Critical Care guidelines, they have very weak recommendations about using neuromuscular blocking agent in the status asthmaticus. As a matter of fact, they vote against it, but there is no good and strong evidence behind their recommendations, and because of that, they decide not to use it routinely for status asthmaticus patients. There's no clinical outcome evidence. There's maybe increase the ICU weakness. Do you know why? Why there's increase the ICU weakness when you use it in status asthmaticus? because most of the time we use steroid in status asthmaticus. So there is good relation between use steroid and neuromuscular blocking agents. So my home messages for this, take home messages for this, try to avoid it in patients with status asthmaticus. You have to have deep sedation in those type of patients because irritations cause more exacerbation of their asthma. And you might use it in severe life-threatening hypothermia only, so not in every single asthmaticus come to the ICU, and or if there's any dynamic hyperinflation. But do not use it. Do not use neuromuscular blocking agents routinely for status asthmaticus. Great. So what about elevated intracranial pressure and trauma? Now I looked at National Guard, guidelines and head trauma, and luckily enough, they don't try, have any strong, statement about use of neuromuscular blocking agents in patients with head injury. And they are right, because most of the guidelines, they have very weak recommendations about the utilizations of the neuromuscular blocking agents in patients with head trauma. So there is no big evidence. Now, if you look at the American College of Surgeons Trauma Guidelines in 2015 and updated in 2018, they mentioned if you want to use it, you have to use it in the second level, the second tier of your intervention. If you think the ICV is high, or if the ICV is high, regards all the measures that you've been doing for your patient, then give bolus, give only bolus of cisatracorium. See the response to the ICV. If the ICV come down after your bolus of neuromuscular blocking agent, then you go to the stage 3 of continued infusion for 24-hour reassess afterward. But do not give it routinely unless the ICV is in situ, plus you give a bolus and you show the evidence of giving the neuromuscular blocking agent. And this is the guidelines. You can have the slides. So my take-home messages for patients with elevated intracranial pressure: there is weak evidence. Routine use is not recommended. No improvement. So the take-home message is there is weak evidence that we introduce therapeutic hypothermia. Before we do that, let's ask people here: how many of you use therapeutic hypothermia in post-cardiac arrest patients? Do you use it? There is a protocol, right? So, one of the positive articles, they were not using NBA, neuromuscular blocking agent. The other article, they use NBA. So we didn't have a good answer if we need to start to give neuromuscular blocking agent routinely for those patients that we introduce hypothermia on. There's no evidence, but there is ongoing study. Actually, I think it's closed, and they are writing out the manuscript now about it's randomized control trials, registered randomized control trials, looking at the benefit of adding paralysis with a therapeutic hypothermia for patients with post-cardiac arrest. But till now, we didn't have yet good evidence. You block me. So this is the article. We are waiting for this article to come out, and we'll see the result. But there is no evidence. And the American Heart Association guidelines recommend not to use it, not to use paralytic agents in patients with therapeutic hypothermia. So what are the issues now after all of this, literature review about the benefit, if there's any way? Well, there is some issues that we know from literatures. Number one issue is there is no clear evidence, which is very important. There is increased costs, especially with the cisatracorium, which I love to use in case I use neuromuscular agent. The skin breakdown, corneal abrasions, venous thrombosis, and DVTs, ICU acquired lung to ICU witness, and that's the major thing that we are trying to avoid when we are, applying nuts and bundles. And there is inappropriate sedations, because most of the time when you give patient paralysis, you either heavily sedate them or you partially sedate them, so they unfortunately have, the stress of feeling the pain and anxiety attacks while they are paralyzed. Myositis and other problems and allergic reactions. So it's a drug that carries a lot of side effects and complications. So if you want to use it, you have to have your justifications in front of everybody why use it despite all of these complications. Other issues is neuromuscular weakness. We could avoid it by decrease the durations of paralytic agents. Those are some medications that might increase the likelihood of acquired acute quadriplegic myopathy syndrome in patients with on neuromuscular weakening agents. Another issues, it's linked very well with the ICU, long ICU, long hospital stay and increased mortality. As I said, this is a very good article. They look at patients who are paralyzed and deeply sedated, and paralyzed and lightly sedated. Those who are deeply sedated, they have very bad outcome. So deep sedations, even with the paralysis, they have very bad outcomes. So train of 204 is good, cutoff for patients with sedations and paralysis. Myasthenia gravis, be careful with the dose, decrease the dose because they are sensitive to your neuromuscular weakening agent or upgrade. Now, the selections, if you still want to use it, this is the selections slide. If patient has hepatic or renal dysfunctions or they are on the steroid, if this yes to any, start with atracorium. If no, then you can use either vicuronium or ricoronium. This for the cost mainly. Now, if you use atracorium and all of a sudden patient become hypotensive, that means there's a release of histamine or there is diuretic effects, move to the cisatracorium is the way to go. Dosage and clearance. We're not supposed to memorize all the doses now. So what are the things that we have to monitor? We know we cover the literatures behind its use, we cover the side effect, the issues of its use in ICU patients. Now, if in case you still want to use it or your staff still want to use the neuromuscular weakening agent, you could use monitoring technique, and the monitoring are two types. Monitor patient clinically, look at if there is any dyssynchrony between the patient event, if the patient put in the tube or no, and look at the chain of 4 as well. You could use both. Use off here, yeah. And look at all the time, make sure you measure CK every day. Why we measure CK in patients with the neuromuscular weakening agent? Myositis. Great. Now, if you want to stop NBA, you could just stop it without tapering, but be careful. It might take a long time for clearance, especially with the diseases and concomitant medications, before you take the tube out. So train of 4 does not really mean patient is fully awake. So be careful when you extubate those patients. Every day, every hour, every 6 hours, you have to evaluate the need for the neuromuscular agent. Make sure your patient is pain-free. Titrate to the lowest effect. You could use train of 4 or clinical evidence. Make sure that you cover DVT as you for any patient, and start, mobilizations. Start again physiotherapy. Having paralyzed patient does not mean that you should not, do the passive, movement in the patient by the physiotherapy or by the bedside nurse. Eye care is very, very important. There is excellent number of studies to show the benefit of using the eye care in paralyzed patients, decrease the chance of corneal ulcerations and ulcer and blindness. Structural physiotherapy, we mentioned this. Take care of the pressure points in those patients. Again, we talk about train of 4 and 0.9 is the way to go, but even with the point of 9, still there is some patients they cannot breathe in, so you have to make sure the patient starts breathing by themselves before they pull the tube out in those patients. Now, if you use the train of 4 for looking at the neuromuscular blocking agent effect, be careful. We have issues with the train of 4, staff training and experience, and different machines. There are different machines that you could use. So you have to be familiar with machines. Patient who has any problem with the skins that might give you false, impressions as well, especially with the edema patient. Temperature, the skin resistance. And for patients with neuromuscular blocking agent, there is some issues or debate about feeding them. The bottom line is still you could feed them, even there is questionable paralysis of the gastric motility. That's not really true. So you could still feed them, but you have to start slowly, not as the normal or non-NBA patient. Again, daily, there should be no more than 24 to 48 hours infusion of neuromuscular blocking agent. And if this happening, I think this is almost criminal. Every 24 hours, we have to assess the need for the neuromuscular blocking agent in our patient. Otherwise, we are not doing good. We are doing more harm with this. There is no evidence. We are using something without good evidence, and despite of this, we are continuing using it. So be careful with this. So in summary, there's no strong evidence for most of the NBA and most of the conditions. You have to select the right one and with the lower dose possible. Use for short durations. Watch for the side effect. Make sure that you know the interactions between your NBA, the neuromuscular blocking agent, and the other drugs. Watch for complications as well. It's not uncommon to happen. So be careful with those. And monitor clinically and with the TOF as well. And be aware of sudden self-extubation. So by the time you switch off the paralytic agent, make sure there is 1-to-1 bedside nurse, 1-to-1 nurse ratio for your patient. Otherwise, the patient might pull the tube. So that's the conclusion, and I'll take the questions. Any questions? Yes, please. Great. So there is a question here. What about the anti-inflammatory effect of cisatracorium? What do you think about them? Yes, we mentioned there's a good number of evidence that shows most of the neuromuscular blocking agent decrease the inflammatory process in some conditions, especially with the status asthmaticus and the ARDS and septic shock patients. And there's one article about this septic shock patient and NPA and the inflammatory process. But again, we in ICU, we want to look at clinical outcome because we have a lot of medication that improve, markers, but never, go all the way down to clinical outcome. Technology. Thanks, Dr. Zohair. What about, well, I mentioned CURSE trial. It's there. It's very small trials. It's not really big one. And if you want more discussion about it, there is more discussion in the next few slides. But ACROSEL trial is not really good one to look at because of the number of the patients. Thank you for the answer. We'll be answering them shortly. Any other questions? Any other questions? That's very good question. So maybe he put the question before we look at the trial. So here's the trials. This is a small study negative. This is small study, this big one, and it's positive, but it's not blinded study, and it's only one study and has an issues as well. And if you put and I just mentioned earlier, the accuracy style study, it had the same author as the other 5 studies as well in the same center. So difficult to take a judgment call from from one study. And you put all the study together, especially with this one here, with the 1,000 patients, then you could, questioning accuracy study in NBA using RDS. Any other questions? Any other questions from you? So please, do not use neuromuscular blocking agent in your ICU patients unless there is good evidence behind it. Now I'm talking about exactly patients need infusions. We're not talking about, boluses. Now, if you work in an area where there's no consultant, you have to talk to your consultant. If you are working the area that you think that your patient needs neuromuscular blocking agent, it's better to refer your patient to other centers. That's the way that I look at it. Any other questions? So in NASM bundles, one of the major bundles that we have in NASM is utilize or use of neuromuscular blocking agent, paralysis agent in our NASM populations, patients. So from this study, I think we want to see the major drop in the use of neuromuscular blocking, and I can tell you from now, there will be no change. There is no increase in mortality at all by doing so. As a matter of fact, we might decrease the length of stay and the other side effect of paralytic agents in ICU patients. Good question. Any other questions? You guys convinced? Not convinced? Yeah. Great. Okay. Thank you.
Thank you so much, Dr. Zohair, and please, we would like to remind you of the VAE data. Please upload the data, send us scanned copies for validation purposes, and we appreciate all the help. Thank you so much. Please, if you think of any other question, shoot them to me or Cheryl. We'll be ready to forward it to the